Hello and welcome everyone to this session on the Ultimate X-ray Quiz. My name is Dr. Jhanvi. I am the anesthesia educator on Unacademy, and we just had an awesome session on case-based scenarios in medicine, and I hope that you guys will like this session too. It's going to be all case scenarios but with X-rays in it. Alright, so I hope that you guys can see me and hear me well. Yes, the streaming seems absolutely fine and we can go ahead with today's class. So I am an anesthesiologist by profession, and this is the Telegram channel Let's Crack NEET PG, where you will get the links to all the classes that I take. So make sure that you join the Telegram channel and you get the links to all the free classes. Now we have a very interesting All India mock test on the 26th of February at 9 AM, and this will help you get the best preparation for your NEET PG exam. So since you have time now and the exam is in May, I highly recommend all of you all to give this mock test so that you get an idea about where you stand amongst your peers. The Plus subscription on Unacademy will get you access to live and recorded classes. You can learn from India's top educators, you can compete in live tests and quizzes, you can study on the device of your choice, and you can access our question bank with 25,000 plus questions. The Iconic subscription is a partnership between Unacademy and PrepLadder, which will help you get the best of both. So you get the live lectures of Unacademy and the video lectures or the recorded lectures and the question bank of PrepLadder. These are our FMG December toppers. Now along with this, we have a very special thing that is going on right now. So if you buy the Unacademy Plus subscription for 1 year, you will get free notes. Okay, so you can use these free notes for your preparation. So that is something that we are now giving away along with the Unacademy Plus subscription. Along with that, we also have the educator curated test series for every subject. So anesthesia is already done. We have for medicine, ortho, surgery, biochem now. And if you would like to try Unacademy first, you can come for our special classes. Here we have interactive live classes, we have polls, we have raise a hand option, and at the end of the class you also get printed lecture notes. And these are the batches that are going on right now in the Plus subscription: the NEET PG Educator Revision batch, Target Next 2023 subject wise batch, Focus FMG Comprehensive batch, and Focus FMG December batch. So if you would like to join the Unacademy Plus subscription, you can use my code Dr. Jhanvi Live, and with that you can get an extra 10% off on your subscription. Remember, if you buy the 1 year subscription now, you will get free notes coming up. So let's begin with our first question for today. Identify the sinus best seen in this view: frontal, maxillary, ethmoid, or all of the above. Yes, 2 classes today, Mulai. So first of all, identify the view for me and then tell me what is the best sinus that you can see in this view. Alright, so Nishi is saying answer is B, maxillary sinus. Any other answers? And also, can you all tell me what is the view that you all are seeing on X-ray? Okay, Manoj is also saying maxillary. Alright, so very good. This is called as Waters view. Okay, this is Waters view, and in Waters view the best sinus that we can see is maxillary sinus. Awesome. Now tell me, your frontal and ethmoidal sinus will be seen best in which view? Yes, so your frontal sinus and your ethmoidal sinus, all of them will be seen the best in your Caldwell's view. Caldwell's view. Okay, so in Waters view you can see the maxillary sinus best. Now how do you know the maxillary, how do you know that this is Waters view? Just imagine someone is drinking water. So that's the best way to remember this. Look at this, the way my neck is. So that is exactly how your X-ray is taken in the Waters view. Alright, so in the Waters view you will be able to see maxillary sinus best. Alright, identify the sinus best seen in this view: frontal, maxillary, ethmoid, both A and B, or both A and C. Okay, Yash is saying answer is A, frontal. Akshita is saying both A and C. Dental Q is also saying, Manoj is saying both A and B. Okay, first of all, can you tell me what is the name of this view? Yes, this is our Caldwell view, correct? This is our Caldwell view. Now in Caldwell view, what is the best sinuses that we can see? This, the one that is there in the front, that is your frontal sinus, and yahan pe the ethmoidal sinuses. Okay, so the frontal and the ethmoidal sinuses both are seen the best in Caldwell's view. So the answer is both A and C. So please remember from the previous question, those who have come in late, Waters view will help you see the maxillary sinus best, and frontal view, Caldwell view will help you see the frontal and ethmoidal sinus best. Okay. Alright, identify the condition in this barium swallow and give me the treatment of the same and the investigation of choice in the same. Investigation of choice and treatment. Okay. Yes, most of you are answering it correctly. This is nothing but diffuse esophageal spasm. What is the name of this esophagus? On X-ray picture. On X-ray picture, what do we call this? So you call it as nutcracker esophagus, or you can call it as corkscrew esophagus. Okay. Yes. What will be the investigation of choice for this? Investigation of choice is not barium swallow, Narmata Devi. Yeah, investigation of choice is manometry. Okay, so you are going to check the pressures in the esophagus. So investigation of choice will be manometry. What will be the treatment? Anyone? Patient will present with dysphagia to liquids and solids. How will you treat this condition? How do you relax this spasm? So we can give drugs to relax the spasm. What are the two drugs that we can give? One is nitrates and the other one is calcium channel blockers. Okay, so that is our treatment for diffuse esophageal spasm. Alright, any condition that it is associated with DES, any infective condition that DES is associated with? Any idea? They'll say that DES is associated with this disease. Absolutely correct. You are right, Yash. So Trypanosoma cruzi causes diffuse esophageal spasm. Alright. Okay. Next, what is the investigation of choice in this case? Barium swallow, barium enema, 24-hour pH monitoring or 24-hour manometry. Alright, so 24-hour manometry, investigation of choice, absolutely correct. Can you guys tell me what is the condition that you can see here? What is this condition called as? This is not Hirschsprung disease, no. Again, this is a barium swallow only of the esophagus. It is a barium swallow of the esophagus. Remember, in Hirschsprung your colon will be affected. Okay, so you will do a barium enema in that case, not a barium swallow. Barium swallow is done for esophageal disorders. Yes, so here you are seeing bird beak appearance, and this bird beak appearance is seen in case of achalasia cardia. Alright, what will be the medical management and surgical management of this disease? Medical management, surgical management of this disease. What injection will you give? Where? Yes, very good. Botulinum or Botox injection can be given for the medical management, and for surgical management you will do Heller's cardiomyotomy. Okay, so in that you are going to cut through the muscular layers of the esophagus and help in releasing the spasm. Alright, okay. Heller's cardiomyotomy. Okay, alright. What is the treatment in this case? Radiofrequency ablation, nitrates, calcium channel blocker, surgery, botulinum toxin injection. Okay, Mulai is saying botulinum toxin injection, Nishi is saying surgery, Ali Abbas is saying nitrate CCB. So we have all the answers. Someone wants to say RFA also, can say RFA also. First of all, can you identify what radiological investigation is this? What radiological investigation is this, guys? Yes, this is nothing but barium swallow only, correct? We are still looking at barium swallow. Now, what is the diagnosis of this barium swallow? So, diagnosis of this barium swallow is nothing but you are having a apple core appearance. Apple core appearance means it looks like you have bitten into an apple, okay? So, this apple core appearance is seen in which condition? Apple core appearance is seen in case of CA esophagus, okay? And what is the treatment for CA esophagus? Always surgery. So depending on where exactly is the position of the CA esophagus, whether it is adenocarcinoma, squamous cell carcinoma, middle third, lower third, you will go ahead for esophagectomy followed by radiation and chemotherapy. Alright? Okay. This patient presents with breathlessness, pedal edema and symptoms of myocardial infarction. How will the heart sounds be in this case? Increase, decrease, muffled or normal? Yes, you're right. Macion surgery, Ivor Lewis surgery, all those surgeries you can do. Okay, Subrata is saying heart sounds will be muffled. Yash is saying heart sounds will be muffled. Nishi is also saying the same. Why are you all saying there will be muffled heart sounds? What is your diagnosis in this condition? What is the diagnosis that you guys can tell on the basis of the picture? Okay, pericardial effusion, alright. Okay, if I tell you this is a cardiac tamponade, if I tell you that the effusion is nothing but blood and I say that this is a cardiac tamponade, then how will my heart sounds be? They will still be muffled. Okay, so what are we talking about over here? Basically I wanted you to identify the appearance of the heart. This is called as the water bottle heart. Water bottle heart. And what is Beck's triad that you see in case of cardiac tamponade? Can anyone tell me the three things as a part of Beck's triad? Yes, Ali, tell me. What is there in Beck's triad? Raised JVP? Yes. Muffled heart sound? Excellent. And subcutaneous emphysema. That's not the part of the Beck's triad. Along with raised JVP, what will you have? You will have, चलो guys, Beck's triad तो आना ही चाहिए सबको. Decrease pulse? No, it is hypotension. Yes, you're correct, Ali Abbas Sayyed. So Beck's triad involves raised JVP, muffled heart sounds and hypotension. Okay, so in cardiac tamponade you will be able to hear all these three things. So you can see the raised JVP over here. That is why the jugular vein is so distended, IJV, and here you can see your muffled heart sounds. Sorry, your EJV is so distended. Here you can see that your heart sounds are muffled and you are having hypotension, low blood pressure. Okay, alright. This patient delayed a flight at the airport and had to be offloaded due to acute abdominal pain. So this patient is traveling somewhere. Suddenly he goes into the aeroplane and he starts complaining of acute abdominal pain, and then they delay the flight, get medical attention, and finally leave him at the airport. So what is he suffering from? Intestinal obstruction, sigmoid volvulus, contraband carrier, or uterine rupture? Okay, so Raja Deepan is saying C. Any other answers? Yash is also saying C. Yes, absolutely correct. So contraband carrier means nothing but drugs carrier. Okay, someone who's carrying drugs. Now, where all can you hide the drugs? So as you can see in the picture over here, the drugs are hidden in the rectum. Okay, so here the drugs are hidden in the rectum, and that is why what happens is suddenly there will be some amount of drug that starts leaking, and the patient, since the drugs that are carried are mostly sympathomimetic, the patient sorry, not the patient, the person who's carrying the contraband mean drugs, they will start getting all symptoms of sympathetic activity like dilated pupils, they will have hypertension, tachycardia, and they can even die. Okay, so they can actually die if these drugs end up leaking. So this contraband carrier is now presenting with acute abdominal pain because the drugs have leaked. So he has to be taken off and offloaded. Alright? Okay. Identify this fracture. Monteggia fracture, nightstick fracture, Schoffer's fracture, or Galeazzi fracture. Okay, Raja Deepan is saying answer is D. Any other answers? Alright, Manoj, welcome back to class. D. Subrata Mulai are saying Schoffer's fracture. Okay, so can you tell me what is the fracture over here? See the fracture line over here? So you are having fracture of the distal 1/3 of the radius, correct? And what has happened over here? Along with the fracture distal 1/3 of the radius, you have dislocation of the radio-ulnar joint. Barabar? Yeah, so you have fracture distal 1/3 of the radius along with dislocation of radio-ulnar joint. So this is the definition of what? This is the definition of Galeazzi fracture. What will be the treatment for this? Any idea? And what is the type of anesthesia given for this? Ye bhi batao. Because this is my specialty, I will ask you guys. What will be the treatment for Galeazzi fracture? Okay, so you will do open reduction, internal fixation along with plating. Okay, you have to do internal fixation along with plating, and this can be done under brachial plexus block. So you give local anesthetic around the brachial plexus and you will be able to carry out the entire surgery. Alright? Okay. Moving on to our next picture. Here can you identify what is the fracture? What is the fracture over here? Welcome to class Staphylococcus. Here you are having fracture of the proximal ulna, and you are having dislocation of the radio-ulnar joint. Yes, absolutely correct. So this is nothing but a Monteggia fracture. Okay, so ulta of Galeazzi fracture is actually Monteggia fracture. In Galeazzi, your radius is getting distal 1/3 of radius is getting fractured. In case of Monteja, your proximal 1/3 of ulna is getting fractured. Okay, yeah. Next question. This patient presents with severe respiratory distress and fall in saturation. What is the treatment? Just wait and watch. Antiviral agents and symptomatic treatment, tracheostomy, nebulized adrenaline and antibiotics. Okay, so Raja Deepan is saying nebulized adrenaline and antibiotics. Any other answers? Manoj is also saying the same. Staphylococcus also the same. So what is your diagnosis? Yes, very good. Okay, so severe respiratory distress is happening and you can see thumb sign in the X-ray. So this is nothing but acute epiglottitis. Acute epiglottitis. Okay, and what is the treatment of acute epiglottitis? To reduce the inflammation of the epiglottis, you will give nebulized adrenaline. And for treatment of the cause, you will give antibiotics. What is the most common cause in this case? Most common cause in this case will be H. influenzae. Okay, please remember this, guys. In patient of acute epiglottitis, he will come with severe respiratory distress and tripod sign. In patient who has croup, what will he come with? Will he come with acute severe respiratory distress, or he will be okay in case of croup or laryngotracheobronchitis? Yeah, in croup he will be okay. He won't be that bad. Alright. Okay. Patient presents with severe respiratory distress and fall in saturation. What is the treatment? Just wait and watch. Antiviral agents and symptomatic treatment, tracheostomy, nebulized adrenaline and antibiotics. Yes, Staphylococcus, absolutely correct. The diagnosis is right. What sign can you see over here? Yeah, so we can see the steeple sign over here. What is steeple sign? If you've been to the church, hopefully all of you all have, you will see the top part of the church, it narrows down like this. So you can see the airway over here, it narrows down like the steeple or the top part of the church. So that is called as steeple sign. Okay, so this, what is the most common causative organism of croup? Yes, it is para-influenza, and that is why the treatment for it is antiviral agents, because it is a viral infection. And symptomatic treatment. Symptomatic treatment may you will give nothing but same nebulized steroids and nebulized adrenaline to reduce the inflammation. Okay. Alright. Now the next thing I wanted to ask you guys was, is this question correct? Have I framed the question correctly, or have I made a mistake in framing the question according to you all? You all can tell me if I am not correct, huh, guys? ऐसा कुछ नहीं है. I am the most approachable teacher. Yes, absolutely correct. So, if the patient has croup or laryngotracheobronchitis, he will never present with severe respiratory distress. Please remember this, okay? He will never present with severe respiratory distress. He will have slight difficulty in breathing. Severe respiratory distress is only in case of acute epiglottitis. Okay. Also, desaturation will not be seen in case of croup. You can see desaturation in epiglottitis but not in croup. Okay. Alright, moving on to our next question. Patient presents with acute abdominal pain and bleeding PV. What is the treatment in this case? Just wait and watch. Surgery, antibiotics or antifungals. Okay, I was just not sure if the video was stuck or no. Yes, okay, so it seems that the video was not stuck. I'm using 100 different devices to carry out the class, and a different Wi-Fi or a internet network is connected to each of them. That's why I'm not able to make out what stops working suddenly. Alright, so most of you have answered this correctly. So surgery is required for the treatment of this. Now what is the surgery that you have to do? So why is she having acute abdominal pain? So this acute abdominal pain and bleeding PV is because she has a displaced intrauterine device. Okay, so this is a displaced copper T, as you can see, and this copper T can also cause perforation. So how will you deal with this? You will do a surgery. Can anyone tell me what surgery will be done? Laparotomy नहीं करना पड़ेगा भाई. You have to go into the uterus and remove it na. This is not inside the abdominal cavity as yet or peritoneal cavity as yet. हाँ आज़ाद, surgery की 9 videos ही है. What do you want me to do? Yes, so you can do a hysteroscopic removal. You can do hysteroscopic removal of this copper T. Okay, please remember this. Can I just leave this copper T just like it is? I'll tell the female that ठीक है, I'll start you on OC pills. That will be an alternate mode of contraception for you. But निकालने की ज़रूरत नहीं है. Now it is embedded in the uterine wall, so it's okay, no problem. Can I just leave it just like that? Okay, remember I can't leave it just like that. Why? A, it is a foreign body, it can get infected. Second, it can perforate through all the layers, endometrium, myometrium, parametrium, and it can go into the peritoneal cavity. Okay, and yes, it can rupture and go into the peritoneal cavity. And the third thing that can happen is there can be continuous bleeding leading to anemia in the patient, and maybe if she gets pregnant by any chance, there can also be an ectopic pregnancy in this case. Okay, so because of all of these reasons, I should not leave this displaced copper T. It will be medico-legal on my part. I should remove it by hysteroscopic removal. Alright, okay, next question. Patient presents with right hypochondrium pain, flatulence after meals. What is the treatment in this case? Appendicectomy, cholecystectomy, exploratory laparotomy, or conservative treatment? Okay, Staphylococcus is saying cholecystectomy. Nishi also same. Alright, everyone wants to do a cholecystectomy. Why? First of all, can you all tell me what is the radiological investigation that you all are seeing in this picture? What is the radiological investigation over here? Yes. So what can I see over here? This is nothing but the gallbladder, and inside it you have nothing but fluid. Okay, and on the base of the gallbladder, basically what I can see is presence of stones, and then beyond the stones I can't see anything because of the posterior acoustic shadow. Okay, so you have stones here, gallbladder stones, cholelithiasis along with posterior acoustic shadow. So this is nothing but cholelithiasis. What is this? This is a typical ecotexture of the liver. Okay, so you should always be able to identify this, not just for your exam but also practically later on in life. It's very important because sometimes you remember in pneumonia they say we have hepatization of the lung. So what do you mean by hepatization of the lung? So the lung starts getting this kind of ecotexture like the liver. Okay, so it's very important. Once you identify the liver parenchyma, you will never make a mistake in all the other organs. So what will I do in this case? Patient is having gallbladder stones which are also symptomatic in nature. So a fat fertile female of 40, I will go ahead with cholecystectomy. Can anyone tell me, if I do a laparoscopic cholecystectomy, what will be my anesthesia of choice in that case? Laparoscopic cholecystectomy, anesthesia of choice. Yes, remember, whenever I do a laparoscopic surgery, my anesthesia of choice will be general anesthesia. Perfect. Okay. Patient presents with pain in abdomen and hematuria. What is the treatment in this case? Conservative treatment, kidney biopsy, Rovsing surgery, symphysiotomy. No, laparoscopic surgery, I will always give GA. Okay. Okay, Narmata is saying Rovsing's. Yes, I said it is saying conservative treatment. See, everyone is going for Rovsing surgery. Okay, can you tell me Rovsing surgery is done in which condition? Everyone who's answering it as Rovsing surgery and is absolutely wrong. It's de-roofing of the cysts. Correct? De-roofing of which cysts? No, Rovsing surgery is not done in horseshoe kidney, correct? Rovsing surgery is de-roofing of the cysts done in polycystic kidney. Am I right? Or am I confused over here? एक बार check करो. Okay, so the diagnosis over here for sure is horseshoe kidney, correct? Diagnosis over here is horseshoe kidney. So can you see over here the kidney, the isthmus of the kidney is joined, either the upper pole or the lower pole is joined, and you can see that the kidney is joined. Alright, so what will you do in that case? In case of horseshoe kidney, nothing. You don't need to separate the kidney from each other. You just need to have conservative treatment. So your treatment is conservative surgery. I'm pretty sure Rovsing surgery is done for polycystic kidney disease, but this is not your polycystic kidney disease. This is nothing but your horseshoe kidney. Okay? Rovsing sign is seen in appendicitis. Rovsing surgery is done in polycystic kidney. Alright? Okay. Alright. So a patient comes to you with acute abdominal pain, lower abdominal pain after a party. He says that he had so much alcohol to drink that he completely lost consciousness, and then he woke up in the morning and he has acute lower abdominal pain. So and he has not passed any motion. So you do a X-ray on him and this is what you find. So what is the diagnosis? Yeah. So moral of the story, first of all, you can see dilated bowel loops over here above. Okay, that is explaining his constipation. There is obstruction. Where is the level of the obstruction? The level of the obstruction is at the level of the rectum. So what has happened? He has passed out and someone has passed a bottle into his rectum. Okay, so this is how you identify. This is nothing but foreign body in the rectum. Everyone is shocked. So you all should like this video only for giving you all these shocking x-rays and you all not being able to diagnose these shocking x-rays. Alright, now easy one. This is the CT brain of a patient involved in a road traffic accident. GCS of the patient is 6/15. What is the treatment? Wait and watch for midline shift. Emergency neurosurgery. Give FFP and cryo to stop bleeding. Insert a ventricular drain to drain the blood. Okay, first of all, can you guys tell me what is the diagnosis over here? This is foreign body. Acha, that was foreign body. I think Azad is still watching the previous picture. Alright, so what is the diagnosis? Yes, we have E for Idli. This is a CT scan of the brain showing acute hemorrhage over here, and Idli looking hemorrhage is nothing but EDH, extradural hemorrhage. Okay, so this is the CT of a patient and GCS is 6/15. Barabar? So if the GCS of the patient is so low, you have to immediately do something to improve the GCS. And what can you do? You have to evacuate the blood. So what has to be done in this case? Emergency neurosurgery. Remember, he is a patient of trauma. So there is some shearing of the blood vessels in the brain. So whenever you have the blood vessels of the brain traumatized, you have to stop the bleeding. You just can't just leave it like that. If you give FFP and cryo, it's not going to help in stopping the bleeding. You will replace the coagulation factors, but the trauma that is there to the capillaries or vessels will not stop, correct? If you insert the ventricular drain, you can drain the hemorrhage. Of course, you can do that. But What about the ongoing bleeding? You have to take care of the ongoing bleeding also, otherwise the patient will bleed to death. Okay, wait and watch for midline shift. I don't think there is any requirement for that, because the patient's GCS is already very low, so that means the patient's prognosis is already guarded, so you will immediately go for emergency neurosurgery. Now, as an anesthetist, if you have to induce this patient, what is the drug of choice for induction in this patient? As an anesthetist, if you have to induce this patient, how will you induce? With which drug? Midline shift has already occurred. Yes, very good. So drug of choice for neurosurgery will be thiopentone. Okay, now give me 4 ways how I can reduce the ICP in this patient. Already, because of the ongoing bleeding, the ICP will be high in this patient, correct? So give me 4 ways that I can do intraoperatively which will reduce the intracranial pressure of the patient. Four things that I can do to reduce intracranial pressure. Yes, very good. I can give mannitol. Second, I can give mannitol. I can give other osmotic diuretics also. Anything else? Evacuation surgery, I am already doing it to reduce the ICP. Okay, so decompression. Can I do anything to the EtCO2? Very good. I can give reverse Trendelenburg position, so that will increase the venous return from the brain to the heart, and that will empty the brain from the excessive venous blood flow. Okay, so reverse Trendelenburg position. And the last one is I can give hypercapnia to the patient. Okay, so I can hyperventilate the patient. If I hyperventilate the patient, I will reduce the EtCO2. If I reduce the EtCO2 in the patient, then there will be reduced blood flow to the brain, and that will cause fall in ICP. Alright, can you identify this for me? Another patient coming with this CT scan. What is this? Position. Head down is Trendelenburg position. Okay, head up is reverse Trendelenburg position. Yeah, this is an example of SDH. This is subdural hemorrhage. Okay. What is the treatment in this case? Positive pressure ventilation, Ryle's tube insertion, exploratory laparotomy, or all of the above? Okay, so Akash is saying B, Ryle's tube insertion. Mulay is saying exploratory laparotomy, positive pressure ventilation. Alright, so what is the diagnosis in this case, guys? Diagnosis, confirmation, bedside test. Yes, absolutely correct. So this is nothing but diaphragmatic hernia, congenital diaphragmatic hernia coming from the left side. It's mostly left posterolateral, so this is Bogdalic hernia. How do I diagnose? I can put my stethoscope over here and I will hear gurgling sounds in the chest. How do I confirm the condition? Any idea? Confirmation of the condition is by same bedside test that is used to confirm is by auscultating, and you can hear the gurgling sounds in the chest cavity. Now, what is my treatment for this? Already one thing has been done, that is intubation of the patient. Can you see the tube? So intubation has been done. So I am going to give positive pressure ventilation. So how will positive pressure ventilation help? It will inflate this lung, the one that has been pushed down by the bowel. Okay, when the lung gets inflated, it pushes down these bowel loops into the back into the abdominal cavity. I can put Ryle's tube inside the stomach, and I can also suck out the air from the stomach so that the entire thing collapses. And the third thing I can do is exploratory laparotomy. By this, what will I do? I'll push the bowel back into the abdominal cavity and place a mesh over here so that the hernia can not occur again. Okay, so that is my treatment for congenital diaphragmatic hernia. Okay, alright, moving on to our next question. Patient comes with acute abdominal pain and history of recurrent gastritis. Identify the condition in this case. Ruptured ectopic pregnancy, TB, ileum, ruptured gastric ulcer, gastric outlet obstruction. Okay, so most of you all are answering it correctly. So because patient is having acute abdominal pain and recurrent gastritis, that means he has an acute on chronic gastric ulcer. Acute on chronic gastric ulcer. Barabar? So as a result of this, what has happened over here? There has been perforation. And what can you see over here? You can see free gas under the right hemidiaphragm. Okay, remember, if under the left hemidiaphragm you can see free gas, that can be normal, that can be because of some amount of air that is left in the fundus of the stomach. But under the right hemidiaphragm, if you are seeing free gas over here, that means there is some kind of rupture. Okay, so what has ruptured? Ectopic pregnancy seems unlikely. With the case scenario that is given, ruptured gastric ulcer seems very likely. Okay, alright. Identify the investigation shown in this picture. Barium swallow, plain X-ray, barium infusion, barium enema. Okay, first of all, barium cannot be given as infusion. It is toxic. This is not a plain X-ray. There is definitely some contrast which is showing you the arrangement of the bowel so well. Now, barium swallow is only for esophagus and for the stomach. Here you are seeing the ascending colon, transverse and sigmoid colon very well. So that means that you have given the contrast through the rectum. So this is nothing but barium enema. Okay, so this is barium enema that you can see. Alright. Okay. Where are the leads of the pacemaker entering? Right atrium, right ventricle, left ventricle, both A and B, both A and C. Okay, Narmata Devi is saying right atrium. अभी इससे इजी तो तुमको मिलेगा नहीं है एग्जाम में. If you have some nice examiner na who wants all of you all to come first, does not want any first, second, third ranking, he will give you this kind of an X-ray. What can you see in this kind of an X-ray? You can see that arrows are marked at the things that have to be noted. Now it is highly unlikely कि ऐसा कुछ एग्जाम में देंगे, or you can hope and pray that God makes me the examiner. But here you can see that the leads are seen. Okay, so one lead that you can see is going into the right side of the heart near the atrium, and the second lead is just going ahead of it. It's going the same way, it's just going ahead of it. So obviously if it's going along the same path, it will go down to the ventricle of the same side. So it is going to both A and B, right atrium and right ventricle. Always remember, when a pacing of the heart is done, either they do mostly biventricular pacing, so there will be right atrium, right ventricle, left ventricle pacing, or they will pace any one side of the heart. Okay, ऐसा नहीं होगा कि यहाँ का atrium और उधर का ventricle pace कर रहे होंगे. It will be either right atrium, right ventricle, or left atrium, left ventricle. Alright. So, and this is the lead generator. This is called as the lead generator. That is the main box or the body of the pacemaker. Sometimes they ask what is it made up of. So just remember it is made up of lithium, so that it lasts for a long period of time. Okay, because you can't have a pacemaker of a person stops working if the battery is over, so you need something which has a long lasting battery. ठीक है, it's not like your TV remote battery की बंद हो जाएगा तो problem नहीं होगा, pacemaker बंद हो गया तो आदमी भी बंद हो गया. Alright, okay. What is the well known complication of this procedure? Pleural effusion, hemothorax, pericardial effusion or pneumothorax? Okay, so all of you are answering absolutely correctly. What is the procedure that is done over here? The procedure is nothing but central line insertion. Barabar? Procedure is nothing but central line insertion. And what is the well known complication? It is pneumothorax. If you puncture into the pleura, you can cause pneumothorax. Can you cause hemothorax? Yes, if you puncture into any of the arteries instead of venous cannulation. If you puncture the subclavian artery or the carotid artery, it can cause continuous bleeding into the thorax and cause hemothorax. Okay, pleural effusion cannot be caused by it. Pericardial effusion also cannot be caused by it. But the most common complication that we have heard of is pneumothorax. How will you know that this patient is having a pneumothorax? What will be the presentation? If you're inserting a central line, what is the symptoms you should look for in the patient that will give you an idea कि probably pneumothorax हो रहा है? So you will start getting hypotension, desaturation and arrhythmias. Okay, which is the most commonly used vein? Overall, for cannulation of central veins, most commonly used is IJV. Okay, if you want a long term cannulation, maybe more than a week, like ICU patients, so in that case we put subclavian vein, because the patients will feel uncomfortable with the neck vein, so you put it in the subclavian vein. Okay, chances of subclavian vein में cannulation में pneumothorax chances are high, that's why we don't like to put it much, but you can put it. Alright, and the maximum chances of infection are if you put a femoral vein cannulation. Alright. Okay, what is the immediate treatment of the below condition? Insert a Rice tube, insert an ICD, needle thoracocentesis or conservative treatment? Okay, awesome. So most of you all have diagnosed this correctly. So you are getting the deep sulcus sign, in which this side of the diaphragm has been completely pushed down. You can see no lung enhancement over here. So there are no lung markings, and all you can see is air in between the visceral and the parietal pleura. So this is nothing but a left-sided pneumothorax. Perfect, left-sided pneumothorax. What will be your treatment for left-sided pneumothorax? You will immediately do a immediate treatment. If they are asking, you can do a needle thoracocentesis, and if they ask you definitive treatment, then definitive treatment will be insertion of an ICD. Okay, now can you tell me, in adults, where will you put the needle for needle thoracocentesis, and in pediatrics, where will you put the needle for needle thoracocentesis? Exactly which space, which line, everything. Definitive treatment is ICD. Immediate treatment will be needle thoracocentesis. Yes, absolutely correct. So in adults, we will put it in the 5th intercostal space in the mid axillary line, and in pediatrics we will put it in the 2nd intercostal space in the mid clavicular line. Okay, all right. Now just showing you the X-ray, can you identify the pathology? anything that you guys can see abnormal over here. It's an X-ray of the neck. If I give you any more idea about it, you all will understand. That's why I don't want to give. No, it's not fracture of the cervical spine. No, something very obvious. It's not acute laryngotracheobronchitis. Very good, Raja Deepan. Okay, so what can you see over here? You are having a laryngocele. You are having a laryngocele. Now, what the second hint that I would have given you all is this patient is a trumpet blower. So, शादी में trumpet उड़ाता है. But that is not the case. I didn't want to give you all an idea about it. So this is the diagnosis of a laryngocele. Alright. Okay. A chronic alcoholic patient comes with acute abdominal pain. 4 weeks after this episode, this is a CT scan. What should be done? Conserve, drain under USG guidance, test fluid for TB bacilli or cystogegnostomy. Okay, all right. So what is the diagnosis over here, guys? He's chronic alcoholic. He had acute abdominal pain. I think you all don't need even more idea to say that he had acute pancreatitis. Barabar. Now 4 weeks after his acute pancreatitis, he is having a collection, and this collection is nothing but, what should this collection be? This collection should be pseudocyst of the pancreas. Barabar. So 4 weeks after acute pancreatitis, you are developing pseudocyst of the pancreas. So what is the treatment for pseudocyst of pancreas? Why so much confusion? Barabar. What is the treatment? Treatment will be cystogegnostomy. Correct? Drain the cyst into the jejunum. So cystogegnostomy is treatment of pseudocyst of the pancreas. Okay. Can anyone tell me what is the size of the pseudocyst of the pancreas beyond which you should drain it? If the size is so much, if the age of the pseudocyst of the pancreas is beyond so many weeks, you should go ahead and drain it and not just follow conservative management. Pata hai? Okay, so size of the pseudocyst of the pancreas, if it is more than 5 cm, age of the pseudocyst of the pancreas if it is more than 6 weeks. Okay, that is when you should be going ahead, or if it gets infected. If it gets infected, then in that case you should go ahead and drain the pseudocyst of the pancreas. Okay, sorry, Alright. Next. A 55-year-old female comes with pain in the pelvis, menorrhagia and anemia. Identify the condition. Uterine cancer, CA cervix, foreign body in uterus, uterine fibroid. If more than 6 weeks old, Raja. If less than 6 weeks, you can still give conservative treatment. But if it's not resolving beyond 6 weeks, then you should drain it. Yes, absolutely correct. So, looking at the question, she is having pelvic pain, she is having menorrhagia, she is having anemia. Okay, so you can diagnose from here. There is something that is wrong in the uterus. Okay, that is the place where the problem is going to lie. Now, what can you see in the uterus over here? You can see some enhancing body. It could be a foreign body, yes, that is possible. But the menorrhagia is giving it away. It could rather be a calcified fibroid. Okay, so because of the calcification, you can see the very enhanced picture of the fibroid, and the menorrhagia and anemia is giving off the identification that it is a uterine fibroid. Alright. Okay, moving on to our next picture. Can you identify what type of hip dislocation does this patient have? What type of hip dislocation does this patient have? Left? No, I am asking you what type of hip dislocation, anterior or posterior? So how is the leg? First of all, yes. So how is the leg? The leg is in farther position. Barabar? What is farther position? It is flexed. It is adducted. It's going inside. It's adducted and it is internally rotated. Okay. So this is seen in case of posterior dislocation of hip. Okay. Now what hip dislocation are we having in this? Flexed, abducted and externally rotated. So this is nothing but anterior dislocation of the hip. Okay, alright. Identify the part of the bowel distended. Duodenum, jejunum, ascending colon or descending colon. Okay, so first of all you should know whether this is centrally located or it is peripherally located. Barabar? So here these bowel loops that you can see are centrally located. So whenever you have centrally located bowel loops, we are looking at small bowel. Whenever you have peripherally located bowel loops, either then we are looking at the large bowel. Alright. So when we are talking about the centrally located dilated bowel loops, this is part of the small bowel. Now which part of the small bowel is it? You have to diagnose. Is it the jejunum? Is it the ileum? Is it the duodenum? So duodenum is not seen very easily. In the jejunum you can see the presence of these rings. What is the name of these rings? The name of these rings are nothing but valvulae conniventis. Okay, valvulae conniventis. So this is nothing but jejunum. Alright. Okay. Moving on to our next picture. Identify the condition. Hydrosalpinx, hydroureter, displaced copperty or unicornuate uterus. What is stuck? No staphylococcus, it is only stuck for you, not for the others. Okay, can anyone identify what is the diagnosis over here? What is the radiological investigation? Radiological investigation? Yeah, you are giving hysteroscopic contrast injection. Barabar? Hysteroscopic contrast injection, and what are you seeing over here? You are seeing dilated fallopian tubes. So these, you can see the normal looking uterus but dilated fallopian tubes. Okay, so these dilated fallopian tubes are giving you a idea of hydrosalpinx. Okay, so this investigation is hysterosalpingography and it is showing you a presence of hydrosalpinx. Alright, tobacco pouch appearance, absolutely correct. Okay. What is this radiological investigation? What is the diagnosis? Last 5 slides, guys. Quickly we'll finish it. So what is the radiological investigation? What is the diagnosis? It is a USG, absolutely correct. Okay. Let me give you the background behind this USG. So this patient is suffering from infertility and you have induced her and you have given her clomiphene citrate. So she is coming after a few days and you do her USG and you find this necklace pattern. So what are we talking about over here? Necklace pattern. What are we talking about here? Yes, absolutely correct. This is called as string of pearls appearance. String of pearls appearance. Seen in which condition? This is not PCOS. See the no, but you guys, I have given her clomiphene citrate. Yeah, this string of pearls appearance is not exclusive of PCOS. If I am giving you a case scenario like this, that the patient is having infertility and she is on clomiphene citrate, and what does clomiphene citrate do? It causes increase in it stimulates the ovaries. So this is your ovarian hyperstimulation syndrome. Of course it can pass off as PCOS also, but in PCOS I would have given you another case scenario, that this is a case of infertility and the patient comes to me with excessive hair growth on the face, and she is also having irregular menses, and she is complaining of weight gain. Okay, when I give you this kind of picture with this kind of clinical scenario, you can go for PCOS. But if I am giving you this kind of clinical picture, patient with infertility and clomiphene citrate used for induction, then you rather go for OHSS. Alright. Okay. Here this now exactly looks like OHSS, but you have to be very careful. You can also pass this off as PCOS. So make sure that you read the clinical case scenario properly and then answer. Okay. Alright. And the last picture for today, no, we have two more pictures left. So what is this? This is PCOS. Yeah, so what sign is this? What am I getting over here? Yes, this is my double bubble sign. Double bubble sign. I have a dilated stomach and I have a dilated duodenum. So this is seen in case of duodenal atresia. Okay. If you are telling me double bubble sign, can you tell me single bubble sign is seen in what case? Single bubble sign is seen in what? Single bubble sign is seen in hypertrophic pyloric stenosis. Absolutely correct. Okay. Identify the electrolyte abnormality in this condition. Hypochloremic metabolic alkalosis, hypochloremic metabolic acidosis, hyperchloremic metabolic alkalosis, hyperchloremic metabolic alkalosis. Okay, what is the condition? All of you all who are answering, what is the condition? First tell me the diagnosis. Alright, so the diagnosis, as all of you all can see, there is muscle thickness in the pyloric canal and there is elongation of the channel length. Okay, so this is nothing but idiopathic hypertrophic pyloric stenosis. Absolutely correct. And in case of pyloric stenosis, what are you going to have? The child is going to vomit all the food and the gastric acid out. So if the gastric acid is getting lost, you are going to lose chloride. So you are going to have hypochloremia. Okay. Second thing you will also lose is your H plus ions. So when you lose your H plus ions, you will have alkalosis. Okay. So this patient is going to end up in hypochloremic metabolic alkalosis. Absolutely correct. Okay. Will the vomiting in this case be bilious or non-bilious? In IHPSS, vomiting is bilious or non-bilious? pyloric stenosis, your bile joints are the level of the second part of the duodenum. Okay, so if the pylorus is stenosed, bile cannot join in, so there will be non-bilious vomiting. Okay. Last question for today. Identify the bone fractured. Olecranon process of ulna, radial head, tibia or patella. Yes, very good. So you all of you all can identify, this is femur, this is your fibula, this in front of it is your tibia, and this is the knee, and your patella is completely broken into two parts. So this is your patella, and what will be your treatment? Your treatment for this will be nothing but tension band wiring. Alright. What is the other bone for which we can do tension band wiring for fracture? Any other bone for which we can do tension band wiring for fracture? Next YouTube class, hopefully tomorrow morning, we can do it for olecranon process of ulna. Okay, yeah. Alright, so quickly just recapping the images we have done till now. So this is fracture of the patella, this is idiopathic hypertrophic pyloric stenosis, this is a picture of duodenal atresia, double bubble sign, then OHSS and PCOS, and we have hydrosalpinx by hysterosalpingography. We have duodenal atresia, sorry, this is jejunum, valvulae conniventus are seen, anterior dislocation of the hip, Faber position, posterior dislocation of the hip, Faber position, calcified fibroid, then we have pseudocyst of the pancreas, we have laryngocele over here, pneumothorax, central venous cannulation, pacemaker leads, barium enema, perforation, perforative peritonitis, congenital diaphragmatic hernia, SDH, EDH, foreign body in the rectum, horseshoe kidney, cholelithiasis, copper T displaced in the uterus, laryngotracheobronchitis or croup, thumb sign in epiglottitis, Monteggia fracture, a dislocation, this is Galeazzi fracture dislocation, this is contraband carrier, water bottle heart seen in cardiac tamponade, apple core appearance seen in CA esophagus, bird beak appearance seen in achalasia cardia, corkscrew appearance seen in diffuse esophageal spasm, Caldwell view and Waters view. Okay, so with that we end today's class. I hope you all liked it. Please don't forget to leave a thumbs up at the end of it, and also don't forget to join this Telegram group where I will be posting the links to all the classes that will be carried out like this, free classes. Alright, thank you so much and see you next time guys. Bye bye, take care and good night. Hopefully tomorrow morning we will be having one class, okay guys, either on the Unacademy platform, on the special class platform, or on YouTube. So I'll update you guys by tonight on Let's Crack NEET PG group.